ask, we can move on to our final talk of the session from Maria Jantz from the University of Pittsburgh. She is going to be presenting her talk titled Optimizing Spinal Cord Stimulation for Bladder Control Using Evoked Nerve and Muscle Responses. So Maria, you can take it away.
Awesome, thanks. As you said, I'm Maria Jantz. I'm at the University of Pittsburgh with Dr. Robert Gaunt, and I study the effect of epidural spinal cord stimulation on the lower urinary tract. Bladder control may not be the focus of this particular conference, but I think it's important to understand the implications of losing it before we move on into this talk. Bladder control is something that has a huge impact on your lifestyle. You might not have to think about it every day, but the things that you don't think about are always the things that are hardest to lose. So if you think, for example, about like going on vacation and having to try to figure out where bathrooms are all the time, carrying sterile catheters anywhere you go, this is a real struggle. I'll use lower urinary tract dysfunction can come from a number of sources. One of them would be spinal cord injury. Restoration of bladder control is consistently ranked as the first or second priority by people with spinal cord injuries. There are also disorders like overactive bladder, which affects 1 in 8 people, so it's quite common, and can lead to things like poor sleep, as well as avoidance of activities and travel, because bathrooms are maybe not available. So completely restoring effective function requires 2 parts. You have to restore both continence and voiding in order to have complete functional bladder control. There are a couple of ways that people currently try to intervene for bladder control. Catheters are one of them, but maintaining sterility is really difficult in order to avoid infection. If you have compromised hand function, it's difficult to insert a catheter, and it's just not comfortable. If you think about trying to insert a catheter, say 6 to 8 times a day, that's not something you want to do. It leads to scarring. So current healthcare guidelines actually aim to minimize catheter use. And despite all of these problems with catheters, their clean intermittent catheterization is actually the gold standard in this area right now. So there's a lot of work to be done. There are also some pharmaceutical options, but those of course come with their own side effects. And there's a third option, which is what I'm interested in, and that's neuromodulation in order to interface with the neural control of the bladder. So in order to get at how we're going to interface here, I'm going to give you a quick background in the sensorimotor control of the bladder, focusing here on the pelvic and pudendal nerves shown in this illustration, which are critical to bladder control. They're both innervated from the sacral spinal cord. I'm simplifying this diagram a bit. We're working in a cat model, and that's what's illustrated here. But you can think broadly of the pelvic nerve as supplying the bladder itself. So the efferents of the pelvic nerve contract the bladder, the afferents convey bladder sensation, while the pudendal nerve efferents contract the external urethral sphincter, and the afferents convey genital sensation. And pudendal nerve afferent activity, activating those afferents can also allow you to access reflex loops for both continence and voiding, those functions that we're looking for. So in order to produce activity in these nerves, we'd like to use epidural spinal cord stimulation, which is used widely for chronic back pain in something like 50,000 people per year. And more recently has been used in spinal cord injury patients for things like locomotion as well as bladder control. And so in order to access the nerves of the lower urinary tract that I showed you on the last slide, we're using these sacral spinal cord placements here. And we're also using high density arrays. So we just have a lot of potential locations where we can stimulate. There are 2 main effects of epidural spinal cord stimulation that we're looking at, and I'll show data for both of these in a moment. The first one is to see the nerve responses, so we can activate bladder afferent pathways. And the second one is looking for changes in function in both continence and voiding. So we're eliciting both of those bladder reflexes, and we're measuring those functional changes as bladder pressure. So our goal here is then to relate these two these 2 response types, this SCS evoked nerve responses to the function or bladder pressure changes that we're producing. We want to see, we're curious if we can predict functional outcomes from just the neural activity, because we know that we can produce reflexes and nerve activation. We don't know the exact relationship between the 2 of those. There's a second reason that this is useful, which is that We're using these high density arrays, and that means that there are different possible responses at every electrode for 40 to 96 electrodes. And it's much faster to test neural activation than bladder pressure changes. So from a clinical perspective, this is a quick way to find a good stimulation location. So this is a rough outline of our instrumentation. We're doing, of course, epidural spinal cord stimulation on the sacral cord and cauda equina in anesthetized cats. And then we're recording on these lower urinary tract nerves, the pelvic nerve, the pudendal nerve and its branches, and the sciatic nerve to measure off-target effects, so like lower limb movement that we might be causing. Also EMGs to measure muscle activity in places like the external urethral sphincter. And we're recording bladder pressure with just a bladder catheter. So we're looking at this relationship between evoked nerve activity and lower urinary tract reflexes. So we're going to look first at an example of lower urinary tract afferent activity that we're able to evoke. So this is a stimulation triggered average of the nerve activity that we're evoking. And this gray bar is the stimulation window. And we're taking the window following stimulation of each of these stimulus pulses of a stimulus train applied at 3 to 33 hertz frequencies, and averaging all of these windows together. So in this example, pudendal nerve cuff activity, you can see this large initial response, as well as some of this later activity in this boxed area here. So we expect some simple predictors of bladder pressure. We expect the pudendal nerve, afferents are involved in both voiding and continence reflexes, so we would expect that nerve to be active during any good functional response. The pelvic nerve is likely active if we're able to produce bladder contractions. And the external urethral sphincter EMG is likely, if it's actively contracting, it's likely associated with continence or a guarding reflex. So what do these functional responses that we're able to evoke actually look like? These are some bladder pressure recordings that we're looking at. We've got several trials overlaid for each of these, all from one cat. So the blue here indicates a voiding trial, and the green here indicates a continence trial throughout the talk. It's very typical in neuromodulation of the lower urinary tract to have a higher frequency evoke a voiding response and a lower frequency evoke a continence response, even on the same electrodes that you're stimulating. So note these background contractions ongoing. That's very typical in the bladder at rest. And then you can see this nice bladder contraction, this voiding response that we're able to evoke, as well as this cessation of background contractions, this continence-like reaction that we're able to evoke. So we're able to produce both of these components of bladder control with spinal cord stimulation. Just in case you're concerned that our lives are too easy, this also doesn't work sometimes. So these are some examples of poor function at either of these frequencies. So we've got some poor function examples where, again, we have the background contractions. Something happens here, but it's not either voiding or continence-like. And then we have examples where there was just no function evoked. So we're curious then if we can predict these types of functional outcomes from just the neural activity, both voiding versus continence, as well as good function versus poor function. We're going to look at this by extracting features from the muscle and nerve cuff recordings. And we'll use these features first independently to predict based on each feature individually, and then to combine them into a feature vector in order to predict based on all of the features of all the nerves and muscles. So a couple of the time and amplitude features that we extracted here are things like time of the maximum amplitude, peak to peak amplitude, and time of the response, those sorts of things, as well as mean absolute values of 2 millisecond windows, just to get a sense for the evolution of the response over time. So I've done this in several animals. Because we're short on time, I'm just going to have us looking at one here. Peak to peak amplitudes are a straightforward measure of just how much of a response you're getting. So in this example here, this is the pudendal nerve. I've plotted the amplitude of the peak to peak response on the pudendal nerve during trials classified as voiding in blue, continence in green, poor function and no function. And if you'll recall, we would have expected the pudendal nerve to be active during any good functional response. And you can see to a certain extent that that's true, that there's generally less pudendal nerve activation in the poor and no function examples and more in the continence and voiding examples. And you can also see in this example that we have higher pudendal nerve activation in continence than in voiding. So that seems like a promising indicator for our ability to separate these things out. However, this example by itself, this feature is not enough to fully predict the kinds of functions that we're getting. So let's look at the pelvic nerve and the external urethral sphincter. These are roughly sorted from most to least separable, but of course, even the most separable example is not enough to classify on its own. So in the pelvic nerve here, you would expect the pelvic nerve to be very active during voiding. This does sort of appear to be true, but you can see here that there's quite a lot of pelvic nerve activity in many of these other cases, certainly not enough to classify based on this feature alone. If you look at external urethral sphincter EMG, note that this one is in terms of max amplitude rather than peak to peak amplitude, just because the EMG signals are rectified here. So we would expect the external urethral sphincter to be very involved in continence. And this is honestly even less helpful of a feature to indicate what kind of trial we're getting. It's very hard to separate out any of these values. So there's a key takeaway here that all of our expected predictors by themselves don't appear to be enough to predict the kind of function that we're getting. These single features are not enough. So I've just shown these examples of 3 points out of 128 features total across 10 different channels that we're using to do this prediction. This is too many to deal with, and there is a likely relationship between many of these features. So since we expect some shared structure and we don't want to try to visualize in 128D, we have combined all of these features into one feature vector for each of the trials, and we're using dimensionality reduction to identify a common structure and look for some separation. So looking here, we have used a principal component analysis for dimensionality reduction to generate this space. You can see visually that there's some separation between the continence group, the voiding group, and the poor and no function groups. As it turns out, it's fairly easy to classify differences between this poor function and these good function examples. Those things separate fairly easily. Although you can see visually that these different types of function are separated from each other, those do turn out to be a bit more difficult to separate out, to classify. So in conclusion here, we have been able to use epidural spinal cord stimulation to recruit our afferents of the lower urinary tract and produce all of the bladder functions necessary for effective bladder control. We also have found some simple features of neural activity, which have some ability in some cases to predict functional outcomes, but it's very limited. And none of those features are effective on their own. We can produce then we can predict our functional outcomes with these combined features of nerve and muscle activity. And we'd like to use those to determine the best locations for stimulation. A huge caveat here is that this example shows data that I've manually labeled and it's in a single animal. And so our next step here is to find out how much of this space is common between animals and try to highlight some of the examples of different features that are most effective for predicting these different responses. So this is work that a lot of people have been involved in. I would definitely not be here without them. I want to especially highlight Chaitanya, Ritesh, and Rob, who have been involved in overnight experiments and a lot of talking through ideas, and I'm really lucky to get to work with them, as well as our IT staff and our animal care staff, and of course our funding organizations. Thank you. Any questions?
All right, that was a great talk and a super important area of research. So you definitely don't need to convince me. I thought that was really, really great. So we do have plenty of time for questions if people want to post in the chat or in the Q&A. In the meantime, I'll just say that I was really glad that you looked at did a PCA or some kind of dimensionality reduction across all the features, because I was expecting that it would take a suite of features, especially based on Amit's talk with the spinal cord, where you saw that there were many muscles that are kind of working in coordination. So I was wondering if you could speak a little bit more about what the combination of features are that your PCA is picking up on, either for the classification of success versus not success, and then in that what you said was the trickier contrast between the two different successful trial types.
Yeah, absolutely. So there are some things, one thing that was surprising is that EMG activity is not very predictive. We have several different muscles that we're recording. and that turned out to be less predictive than some of our nerve responses, which is
Do you think that,
particularly surprising.
sorry, I was just gonna ask, do you think that that's because there's more noise in the EMG, or is that for some
That's
other reason?
entirely
And then I'll let
plausible.
you finish. I'm sorry, I didn't mean to cut you off, but I was very surprised
yeah.
that it was a little bit counterintuitive.
It's very counterintuitive. I attribute it partly to noise in the EMG. I mean, EMGs are just harder to keep in place consistently, so that certainly is relevant to that. But I would expect, especially the external urethral sphincter EMG, to be much more predictive than it is.
Yeah.
So that was definitely kind of a surprise. One of the interesting things about doing dimensionality reduction on this was pulling out some of the features that I didn't expect to be very predictive, and they turned out to be. There are also several time-related features. So I mentioned that I had those mean absolute value windows. And so if you look at about like 8 to 10 milliseconds into the response, a lot of like high activity there on a couple of the nerves turns out to be quite predictive as well. So that was very interesting.
That is interesting. So we have a question from Jean who says, thank you for your talk. Would EMG/nerve cuff be a viable option in a clinical setting?
Yeah, that's a fantastic question. So one of the reasons that we're trying to push, we've done a lot of work in the past focusing on nerve cuffs, but that's very, very difficult in a human clinical setting. And so one of the reasons that we're trying to push towards EMG, and one of the reasons I would love to see some features of EMG that are a bit more predictive, is that EMGs are much more effective in a clinical setting. Certainly not super comfortable, but much more plausible as a testing method.
Great. So that is all of the time.